This is WPSL Port St. Lucie, the talk of the Treasure Coast.
From north to south, we have you covered with Dr. Joe in Port St. Lucie and Dr. Ed from Florida Orthopedic Specialists in Stewart. Good morning, doctors.
Hey, good morning, Greg. Good morning, Dr. Southern.
Morning, Greg. Good morning, Dr. Becky. How are y'all?
Hey, we're doing fine. So, how are things going at FOS?
Great. Busy as always. Seems like there's more and more snowbirds who are becoming permanent every year. So, yeah, we're busy, but it's nice to step away from patients and mix it up and do the radio show. So, yeah, thanks for having us.
You bet. So, what's going on that's relatively new in your world?
Not so new, but I guess one thing that Dr. Southern and I have talked a little bit about before, and maybe we want to double click on this topic, is we see a lot of things that are preventable, and I think the one thing that I have my thoughts on right now is weak bone related issues like osteoporosis, osteopenia issues. We don't treat those as directly the preventative management of it. That tends to be something that you're talking about with your primary doctor, but we definitely see the results of that. When you fall and you don't have strong bones and you break your shoulder and Dr. Southern has to put you back together, or fall and break your hip and Dr. Southern has to put you back together. And a lot of these things should be, and in my mind, are very preventable. And so I guess maybe I just wanted to start talking about some of these preventable things that we can help you do so that you don't need our help when things go bad.
Well,
I couldn't agree more. It's a while back. I couldn't put a timeline on it, but the American Academy of Orthopedic Surgeons actually had a campaign called Own the Bone. It was a period of time where orthopedic surgeons were able to do things like DEXA scans, bone density scans in the office, and took a really more, I don't want to say authoritative, but a more proactive role in, like you're talking about, preventative bone health management, not removing it from the hands of the endocrinologist and the primary care doctor. And some females, for example, will use their OBGYN, as their PMD as kind of a crossover. And of course, there's family medicine specialists that are trained in medicine, surgery, Peds, OBGYN, and so forth. But what it came down to for a while, it eventually became a cost situation where, Medicare stopped reimbursing, for bone scans in the office. Like, you actually part of the group when that happened, Dr. Gorthbecki?
No, I wasn't.
So they stopped paying orthopedists to do bone scans. They decided that belonged in the hands.
How stupid is that?
Well, they just decided that I'm sure there's more to it than that. But in theory, if you're not going to be the one treating the medication and interpreting the results, so it's probably where the Medicare was coming at. It was, why do this test in an office where you're going to send it out to somebody else to treat anyway? But it is something that, despite the fact that we might no longer have the diagnostic capabilities, is a conversation that has to be had. But to Dr. Wiersbecki's point, when we see you in the office and you're already osteopenic or osteoporotic, that ship has sailed. It's, we really need to be having the conversation. And this is where I find myself having the conversation with when the patients come in with their family members, with their children and their grandchildren. I get the 70, 80-year-old grandmother, grandfather comes in with their son or daughter. And I hope that son or daughter has sons or daughters at home. And it's really that market that we're trying to capture, where you can't prevent osteoporosis, osteopenia at 70, you can only treat it. You can't prevent osteoporosis, osteopenia at 50, you can only treat it. You can try to prevent osteoporosis, osteopenia when women are in their 20s and even younger.
And it's really interesting that you mentioned that. And So what a lot of people don't understand, so I mean, what we do understand is that, when you're young, when you're a toddler, when you're a teenager, your bones are growing both in length and in density. And it's a very rapid amount that, and how quick or how much density you're getting in your teenage years. And in your 20s and 30s, that is when you're going to have your peak bone density. Your bones are never going to be stronger than they are in your 20s and in your 30s. And from that point on, your bones start to slowly decrease in density for the rest of your life. Now, it can sound a little bit discouraging. Oh no, I'm only losing bone every year. I'm only losing bone as every year goes by, and that is true. And so what we're just trying to do is we're trying to slow the rate at which you're losing bone density. And that's why, as if you compare your scan, your bone mineral density scan now compared to 5 years from now, we're just trying to slow you a bit better than the rest of the population is being slowed. So that way you kind of catch back up. And yeah, it's a little bit defeating, but Father Time, always wins, and we're always, getting a little bit older, losing a little bit of bone density, but we just need to do the best job we can at slowing that. And that means, vitamin D, it means calcium, it means regular exercise, it means strength training. Because if you're not putting a force through it, your body doesn't see the need to have it around. And so you're going to lose it that much more.
Right.
Well, docs, but realistically, I mean, how many of us at 20 or even 30 even think about something like that?
Well, that's the point. And interestingly enough,
people about this.
Right. That's what it's saying. That's why I want to have the conversation with the grandmother, who will tell the daughter, who will tell the granddaughters, and so forth. And it's both men and women, but it's more alarming most often in women than in men in particular. But men are not, completely free of this potential problem. But if you look at the current trends in health and fitness and massive obesity in a young age, and I mean the military, not only recruitment numbers down in the military for various reasons that we can get into on another show. Of the ones that decide that they want to serve, there's an exorbitant percentage of them that can't pass the physical qualifications of it because they're just not fit. So these are the people that used to think about it. If you look at the people 20 years ago, people were going to the gym, they were working out. Teenagers were healthy and 20-year-olds were healthy because they were in the gym and training and so forth. Now they're less likely to go to the gym. They're not doing strength training. There seems to be this current concept, which is slightly an overgeneralization, but younger women are afraid of lifting weights because no one's really teaching them the idea of lean body mass and how important what Dr. Worsbecky was talking about, the stress strain curve and putting extra stressors on your bone. The way your bone responds to extra stress and strain is to become stronger. Now, in a young, healthy patient, you get thicker cortical bone, you get increased cancellous bone, you get all kinds of different bony changes that fast forward 60 years, the body's response to stress strain across an arthritic joint is osteophytes. It's bone spurs. So that's a perfect example that the body knows how to respond to stress strain across its bony structures. Why not take advantage of that when you're younger? And we're not doing that. I mean, we're talking about the baby boomers and that whole aspect of things. I think in 30 or 40 years, we're going to see a real problem with bone health in patients if we don't get after it now.
Right. And I think what we can do now is, that older population that maybe is suffering from osteoporosis or they've had, fractures way too easily, is they're telling the younger generation. And the biggest thing that you can tell them is get involved in sports. Greg, I got a trivia question for you here. Out of all sports, if you were to check a bone density of, let's say, everyone who's in their 30s in all sports, in which sports are you going to find people with the densest bone? Football, basketball, baseball, soccer, crew and whatnot. There are two sports in particular that they produce, those activities, those exercises are going to produce the thickest bone. Any idea?
I would guess soccer and maybe even crew. I mean, I know what those folks in the shells do. I mean, like at our college, Loyola, my goodness, those guys and gals were training all the time.
So it's actually it's football and it's MMA type fighting.
Really?
Yeah. And so,
Well, that's right. There's
back to
women in MMA too. Yeah.
right. And you'd think, well, why wouldn't it be someone like a runner who's just pounding on their bones all the time, and producing that amount of force? It's not just the body weight forces. It's doing resistance training. It's using weights. You have to train the body on that. And I mean, you look at the MMA fighters, I mean, they're having to flip people around. They're doing heavy duty workouts. And just look at those football players. It's a lot of powerlifting. And so that's why it needs to be part of your exercise program, whether you're young or old, to be doing resistance training. Yes, it's great to keep your strength as you get older and older, but it also produces great changes to the bone. And like we said, the most rapid and your ideal time to load your bone and make it as strong as possible before you start to slowly lose bone density is in your 20s and 30s. So you got to get into sports now, when you're young. And it's never too late, but it's better the preventative part.
I see Dr. Ed sobbing because you didn't say lacrosse.
Yeah, lacrosse. I'm sure they're up there, but unfortunately, they didn't take first place. Yeah,
We're okay with that. But honestly, and to Dr. Wierzbicki's point, if you tease it out, he pretty much hit the nail on the head. And it's probably not the sport of MMA. It's probably not the sport of football, but it's the training that the elite level athlete that performs those sports goes through, with the strength training routine, the inline body mechanics, the powerlifting. I mean, that's not to say the soccer player doesn't lift or doesn't work out, but certainly not doing the same amount of resistance training that probably your average football player, American football that is, or your average MMA fighter is putting through. So, and it's a reason when you look at your bone density score, it's why your current score is rated against a pool of healthy 20-year-old patients. That is the baseline. So when someone says, oh, you have a T-score of -2, you're osteopenic, or you have a T-score of -3, you're osteoporotic, we need to put you on medication. That score, that minus score, is a minus score against a score of 0, which is a normal, healthy population of 20-year-old women.
And then you're also compared against people who are, of your age equivalent.
Same age. That's a Z score, right? The T and Z.
Yep, exactly.
So
it's both. And in big picture here, why do we care about this? I mean, if you are 70 years old and you fall, and you are much more likely to break a bone if your bone density is weaker. Dr. Southard, remind me, if a person over the age of 70 falls and breaks their hip, the chances of them or their risk of dying in the next 6 months, what is it? Is it 50% increase? 25 to 50% increase?
25 to 50, yes. That's their increased risk of having a negative outcome inclusive of early expiration. Yeah, it goes up by about 20 to 50% in that 6-month period. It's interesting because you have these conversations with patients. Or hip fractures are one of these unique situations where it causes current stable medical conditions to go haywire. It causes medical conditions that you didn't even know you had to become unroofed. It's, patients that have hip fractures in the hospital, they're problematic. It's just why, our society is pushing to try to get to these patients sooner and sooner and sooner. The old thinking was 72 hours from the time of admission. Now that data still holds true, but we really try to get to the patients within the first 24 to 48 hours if possible, provided they're medically appropriate to go to the operating room. If I have a patient that's sick and ill and maybe is on some type of medication that needs to be held for a period of time, a day or two, but you have to weigh the risks and benefits with early intervention versus delaying for medical reasons. But 72 hours, the patient should have their hip fixed. But getting back to Dr. Joe's point, we did a study when I was in Tampa, looking at proximal humerus fractures and the incidence of additional fractures, and the number one risk factor for getting what we call a fragility fracture or an osteoporotic type fracture, be it in the wrist or the spine or the hip, is a previous fragility fracture. So if you have an older woman that's osteopenic, osteoporotic, falls and has a distal radius wrist fracture, the likelihood that that patient's going to wind up getting a shoulder fracture or a hip fracture or a spinal compression fracture, the odds are astronomically elevated as opposed to your non-fracture patient.
Yep. And we talked about, the worst outcomes here. The worst of the worst is, right, you fall, have a hip fracture, and like we said, 50% chance on average of you compared to if you didn't fall and have that fracture, your odds of dying in the next 6 months are 50% higher because you fell and had that fracture. That's terrible. Now, also consider these other things. When you have osteoporosis, you're at an increased risk for spinal fractures. That's not good. Your spinal cord is right there, and spinal cord is pretty important. If you fall and break your shoulder or your wrist, people have terrible mobility issues after this. Your quality of life is significantly impacted. Right. And so the sooner you get on top of this or take it serious, whether it's now or 5 years, 20 years from now, the sooner you take it serious, you can always do something, and you can help to prevent a bad outcome, a bad quality of life situation.
Right. And just for the listeners out there, just to clarify, what Dr. Wierzbicki, Dr. Joe is saying is your risk of having a negative outcome goes up by 50% from your baseline. That doesn't mean if you go into the hospital with a hip fracture, you got a 50-50 chance of getting out in 6 months. That just means, so don't for all those out there who had a family member that has a hip fracture, you didn't get lucky. It's not, but you take your baseline risk of dying in the next 6 months and compare that to your new relative risk with the hip fracture. That's what we're saying. That number is still very frightening.
Very high, but it's frightening, but it's two different numbers. You're right. Yeah.
Wow. Now the question that comes to mind, and both of you guys are around athletics all the time. Do trainers address this like in, with high school athletes or college athletes? I mean, I've never even heard bone density mentioned except say on this show.
Not really. I mean, they just want you, their job is to get you active, get you strong. And as a byproduct of that, you're going to get this other healthy benefit. So I think that's the key, is just keep people active and exercising, active in sports, and then you're going to see all these secondary benefits.
No, like I said, it's to his point, they're there to protect the athletes and treat the athletes. These are conversations that have to happen in your health class, have to happen at young age. I mean, these are ideas that need to be put into idea of students, and they're in the kindergarten age. It needs to be part of curriculum and education and teaching, both in school and at home. So you provide lifelong change. The percentage of people that the athletic trainer at X high school that they touch is less than 5%, I think. I don't know, you might know the numbers better than I do, Joe. What the percentage of high school athletes that actually play sports within a school. Now, there are certain schools where it's different. I mean, if you go to Avon Old Farms in Connecticut, it's 100%. Every student has to be on a sports team. But if you go to Martin County High School, it's voluntary. So it's most of the students in the schools you go to aren't playing sports. So you can't expect the athletic trainer to be the sole focus. It's really got to come in your health class, your PE class. The whole idea that we're taking physical education out of the requirements for students is, I don't even have a conversation for that. It's just ridiculous. I don't know. What's your take on that?
Yep. I mean, I think the whole thing is get people active and try and develop these lifelong behaviors. We don't want to throw everyone in the gym and say, you have to lift weights, you have to do squats. Like Dr. Sellers, what he would always say as far as just, what kind of exercise is best for me, whatever kind of exercise you are going to do, whatever kind of exercise you like to do, we're just going to get you doing something that you like, and then you're going to do it long term. We don't want to force you to do running or to do the elliptical or the stationary bike because one's better than the other a little bit for this joint or that. We just want to get you active. And so whether it's as a teenager or now, you got to be active. Whatever is safe and appropriate for you, we need to increase your physical activity level.
Yeah. Yep. And you're
right. What's your sport? You seem like maybe a pickleball guy.
Actually, Carol and I like to walk, and we love swimming. Yeah.
That's great.
Yeah. That's a lot easier on my antiquated knees.
Mm-hmm.
It's tough being a fossil, you know that?
Yeah.
No, but to your point, I mean, water aerobics, water therapy, that's some of the best exercise. It's like I said, I think I've had this conversation on this show in the past, and I have this conversation at least 2 or 3 times a day in the office with patients. Having been trained in New York, I mean, and Dr. Joe's point, being from Canada, you're up by Canada, right? Where you're from?
Yeah, Minnesota. Yep. Yeah, we're close.
That's Canada. Yeah.
Essentially, yeah, very similar accent.
Yeah, it's a suburb of Fairbanks, Alaska.
Yeah. So, but try to tell somebody in the inner city of Brooklyn or Manhattan or Minnesota, hey, get in the water, go in the pool, especially if you're dealing with patients that have a low income level, or they don't have the resources to spend a fortune on a gym membership. There were 5 public pools in the city of New York. Some of the so when I did my training, part of my training was in Manhattan, part of my training was in central Brooklyn, and trying to get a patient that lives in Crown Heights, Brooklyn, to go to one of the public pools, which would have cost them a measly $70 a year, but it's a 3-hour ride via subway each direction to get to the pool, and hopefully there's room. In Florida, there's water everywhere. Now, certain bodies of water you might not want to go in, say lakes or ponds or whatnot, because you're not there alone. But there's plenty of pools. There's the ocean. There's the intercoastal.
So, Dr. Southard, with this whole topic of osteopenia, osteoporosis, so we talk about these emergent scenarios where, someone needs a surgery, and yes, the bone is of less quality, and you just, got to make do with what the patient's got. So what about the elective cases? Someone's coming in and saying, I need a shoulder replacement, but there's a well-known history of osteopenia, osteoporosis. And I'm guessing a lot of these principles that you're thinking about applies to the rest of the body when, you're thinking about a hip replacement or a knee replacement. So going in, knowing that, are you telling them, let's delay this, go in and get some treatment with the endocrinologist. Let's theoretically build up the bone, and then the surgery is going to be more successful. I mean, is there studies that say that by doing, 6 months of aggressive treatment for osteoporosis with like a bisphosphonate or some other kind of Fosamax or Prolia type treatment, that builds up the bone enough to a better level where you're going to have a better surgical outcome? Do you have a way that you think about this?
It's interesting, and I'm not overly familiar with any studies that look at that per se, and a lot of it is because I'm not really truly an arthroplasty specialist as far as lower extremities. I will tell you the techniques that we use do change in patients that are severely osteoporotic or osteopenic. For example, you may find a higher percentage in shoulder, for example. You're cementing your implant in as opposed to using a press fit, which is one of these porous coated type stems to allow for bony ingrowth, and in the hip, the same thing. I would say, although the trend is changing drastically, currently there's still a much higher percentage of patients that are having the knee components cemented in. That's just the standard, but the trend towards porous coated femoral implants and tibial implants is increasing. But if you have unhealthy bone, you're less likely to be a candidate for these porous coating, rely on your own bone to grow in. Severe osteoporosis, yeah, I wouldn't. You have to weigh the good with the bad. You're less likely to do an elective procedure on somebody that you're expecting a negative outcome insofar as periprosthetic fracture. And that's really it. Number one is, when you're thinking about joint replacement, the first question is, Can I make the patient's problem better with a joint replacement? Okay, yes or no. So now we're at yes. What type of procedure can I do to make this patient better? Is it a total shoulder? Is it a reverse total shoulder? Is it a total hip? Is it a uni knee, or is it a full knee? And then of course, is this patient healthy enough to undergo the procedure? And like if you wind up having a patient where you're expecting a high incidence of fracture because their bone is incredibly weak, you may not do a procedure on that patient depending on how miserable they are. You may want to buy time to treat their osteoporosis, their osteopenia, before they come in. And that goes back to what we started this whole conversation on, this own the bone and this treatment option. You really hope that as your patient doesn't walk in your office for the most part and needs a total hip right away. Now, there are incidents, there are practices where they're worked up by a medical doctor, there's another service, and you're the end of the line. So a guy like Dr. Powers, for example, legendary, arthroplasty surgeon, a lot of his patients have been through the process, and they may walk in, I'm here for my joint replacement. But they've also gone through the process. They've been seen by medical doctor after medical doctor. So that these patients tend not to fall through the cracks. The ones with the really bad osteoporosis, osteopenia, are the ones that the ER calls you about because they have a hip fracture. And now you have to make a decision, what am I going to do with this person? And that's where, if you do have to do a partial hip replacement for, say, a femoral neck fracture in a very frail, elderly, osteoporotic patient, that patient is getting a cemented implant as opposed to a porous coated press fit implant. A proximal humerus fracture is a perfect example. Over 70, the thinking is the bone's weak. So over 70, 75 years old with a multi-part proximal humerus fracture, those patients get a cemented reverse total shoulder arthroplasty, as opposed to the 65-year-old that gets a plate and screw construct with certain limitations. But the trend is towards fixing fractures, even in the slightly older patient in the upper arm. In the weak bone patient, they get a joint replacement with a cemented implant.
You probably felt quite a few different styles of bone here. I mean, what's osteoporosis bone feel like to you? When you're in there, replacing a shoulder and you're squeezing on that bone or drilling into it. Because I'm guessing you can tell a real difference between really thick bone and when you're operating versus real bone. Does it? Can you describe it or to us? I don't even know what it feels like.
It's probably the simplest thing. To anybody out there, I don't want to simplify what we do for a living, but a lot of surgeons, there are technical jobs that have a corollary to it. So your vascular surgeon and your cardiac surgeon, you can equate that to being almost like a plumber. Orthopedics, we tend to be carpenters, so to speak. So, for anybody out there that's ever had a drill in their hand, take your, drill bit of choice. I'm a Milwaukee guy personally, as are you. Drilling through a piece of oak versus drilling through a piece of pine. It's a completely different concept. Same drill bit, brand new, out of the package, trying to put a 1/2-inch drill bit through a piece of oak or teak or ash, and then taking that same drill bit and trying to put it through the piece of pine that they use on the rafters. Go a little bit further, take a piece of wood off of one of those, not carts, one of the little, blanking on the name of it, the stuff they use with the forklifts, at the pallets. Break off a piece of the pallet. That's older, weaker pine. That even goes through even easier. So you can tell the resistance you get when you're drilling through the bone is significantly less. It's much easier to penetrate the weaker bone. The screws don't hold as much. So then you start looking at using locking screws as opposed to cortical, screws that actually rely on the bone to bite into the bone. You're using more of a construct where you're relying on the interface between the plate and the screw that becomes a partner with the bone as opposed to working with the bone.
Yeah, I like that analogy. It makes a lot of sense. And then you're thinking about, right, as you're drilling into that, okay, what's the weight What am I hanging on there? Is this a picture? Am I hanging a bike on this wall?
Right.
Is this drywall that I just drilled into and you need to, anchor it in place or have some kind of expander? You're doing all of these kinds of calculations in a much more scientific orthopedic way, thinking about the forces that are going through those joints. I like that analogy.
I mean, that you actually made it even better. I mean, think about it, right? So you're hanging something up. You're going to hang something up in your cement brick wall downstairs. You just put a cement, you tap your hole, you put your cement screw in, and that's the end of it. Mm-hmm. You want to hang that same bike on your plywood. I mean, that's in your drywall. You need to get a molly bolt, or you need to get some other kind of adjunct. So think about, they're putting the screw into the cement wall. It's just a screw. It's a screw and your bracket. Putting that into a drywall, now you got to go screw, molly bolt, bracket, which is basically kind of like your cement or your locking screw construct, because if you don't do something to augment that implant, it's going to pull out.
Yeah. I like it.
Wow, this has really been an enlightening morning. I'm just so impressed that Dr. Ed knew about that little Avon Prep. I mean, that was in a little tiny town right near where Carol and I had a house in Burlington, Connecticut. Yeah. Avon Simsbury. Know the area well.
Well, my son almost went to school there.
Really?
Yeah.
Wow.
So when we were, just to get a little side note, obviously coming out of fellowship, we were looking for a job during COVID, transitioned from New York down to Florida. And, it's like, I think most people by now know that my son plays lacrosse, right? So if we wound up in an area of the country where there was no lacrosse, it would have taken, to Dr. Joe's point earlier, an entire avenue of joy away from him, sports and activity and what he wants to do in college and so forth. So we did the tour. We went through Avon, Deerfield, Taft, so on and so forth. And had we wound up in an area that we didn't have the availability, we had it narrowed down. He was signed, sealed, and delivered. He was going to go to Avon, but we were fortunate enough to be in an area where we had lacrosse. So he went to public school and loved it. And same thing now, where he's in a public school down here and loves it. But yep, I know them all, Greg. And interestingly enough, the Avon coach is now the head coach at Community School of Naples, Keith Lee. So all of us Northeasterners are coming down here bringing lacrosse to Florida.
There you go. Well, hey, it's a great sport. It really is. It's truly amazing. No doubt about it. Yeah. Yeah. So, Ed, is that your favorite sport? I mean, was that your favorite sport growing up?
Yeah, I guess so. I mean, I didn't get exposed to lacrosse till I was a middle school student. It was actually my younger brother who is how I got exposed to the sport. My mother and dad signed him up for youth lacrosse. I went to a practice and never had really seen it before, believe it or not. I was a soccer wrestler guy, and lacrosse was one of the, I didn't do lacrosse. I played t-ball growing up and then kind of geared away from t-ball. Never really got into the whole baseball thing. Started throwing the ball around with some kids on the side. Coach came over and said, "Hey, did you ever play lacrosse?" No. Wound up trying out for the middle school team in 7th grade, and that was the end of it. So it became later in life, my go-to sport. And now, of course, obviously it is. I played through high school. I played at the college until I got hurt. And coached for a while and love it. So.
Wow. And Dr. Joe, what's your favorite sport?
I'm a water sports guy. Water skiing, wakeboarding, in the Mississippi, that's what I did. Volleyball, being 6'4", you got to play some volleyball, you got to play some basketball. So those were my sports. But I love watching football the most. I am a football diehard fan. Me and my Tampa Bay Buccaneers.
Yep. Bucks football this Saturday night against the Dolphins. We got the Bucks broadcast. Right? The Bucks on STU and Dolphins on WPSL. So
they're allowed to play. I thought their owner or somebody just got nailed for some type of.
Oh yeah, but that's nothing. So what? that's the owner. Nothing. Believe me. My education, when we opened the LA bureau for ESPN, I was there one day, and our assignment editor said, because of your kind of a foray into law, we're going to have you cover the NFL antitrust trial. Well, that turned into 2 trials. And for almost a year, I was living in that federal courthouse down in downtown Los Angeles. And let me tell you, you talk about skeletons in the owner's closet. They were all revealed, and all of them. I mean, it's like, oh, brother, it was amazing. Yeah, it was very interesting. Very interesting. So, yeah, I wasn't surprised at all. But that's a very tight knit fraternity, and well, we'll see what happens. Condoleezza Rice may raise a little cane now that she's an owner of the Denver Broncos. So, yeah, you never know.
I don't think she bought enough of her percentage to actually have a seat at the table.
Well,
I think she bought enough just so she can make the news.
Well, that could be it too. I have no idea. Well, that may be like what was it? Wasn't J-Lo and her former husband, weren't they partners in the Dolphins or something?
They tried to, what did they try to buy? I forget. They tried to buy
the Marlins, didn't they?
Oh, it was the Marlins, yeah, and they got shot down. I think something happened, and yeah. So,
oh well.
It is what it is.
Yeah, that's it.
So,
wow. Well, yeah, body
340-1590, 340-1590 if you want to give us a call live on air, or if you want to see me, Dr. Wiersbecki, or my partner, Dr. Southard, in clinic, the number for Florida orthopedic specialists is 335-4770, and that'll connect you to either office in Stewart or Port St. Lucie. So Dr. Ed, we were talking a bit about the osteoporosis in the weak bones and some of the risk factors I like to think about too. So smoking is a big one that will absolutely affect your bone growth. Other things, steroids, we talk a lot about. In orthopedics, we use a lot of steroids. I was listening to a guy talk about bone mineral density and the risk of osteoporosis, and he mentioned inhaled corticosteroids. And so actually this morning, my resident and I, we got to doing a data search to see if there was actually a correlation with inhaled corticosteroids and someone having an increased risk of having osteoporosis. And just like I was suspicious of, it takes a very high dose of inhaled corticosteroids for long term for that to actually affect your bones. And so I think about this too. People are always coming in and asking about the steroid injections that we want to give them. I mean, the steroid that we're giving you in the joint is such a minuscule amount of steroid. I mean, your body makes a lot of steroid every single day. And so that one-time dose that we're giving you occasionally is not enough to affect your bone health. But some people like to really get freaked out about this. So, you kind of think about these things. I mean, people who are on a lot of steroid pills, for a long period of time, it is going to affect your bones.
Right.
Or if you have a hormone issue like Cushing's disease, for example, where you're overproducing a certain amount of steroid, it is going to affect your bones. So we need to be careful with oral steroid use. So those are some of the risk factors that I was thinking about.
Okay, yeah, so what if an athlete uses steroids? What does that do to all of it?
Well, if they're on it for a long term, then it can definitely affect their bone density. As far as the short term use, there is theoretical, bone issues, but it's kind of tough to say, a one-time Medrol dose pack or steroid pill that's going to majorly affect your overall bone strength.
Yeah, go ahead.
Sorry, yeah, go ahead.
To his point, it's the chronic, long-term, high-dose steroids, and it's actually what we've learned over time and why a lot of physicians are no longer using steroids as first or even second-line agents. Rheumatoid arthritis, treatment used to be steroids or methotrexate. Now you have these disease-modifying alternatives, DMARDs, the ones you see on the commercial with Mickelson, and all these drugs that end with ab, infliximab, something ab, these are all different kind of class of medications because steroids have a wonderful role in certain disease processes when you need them. However, to Dr. Worsbecky's point, they're not without their problems. So chronic, systemic, oral, inhaled, IV steroids, we really try to avoid those, in the long term. The short runs, like you talked about with the injections for treatments, totally different ballgame. But blood flow, anytime you have blood flow compromised to bone, you have an increased risk of osteoporosis. So smoking, diabetes, any other kind of nicotine abuse, patients, for example, that have sickle cell disease, they have a higher incidence of avascular necrosis of certain areas of the bone. They don't necessarily have osteoporosis, osteopenia, but they have weakness of bone. Bone is a living tissue, just like any other living tissue in our body. It needs oxygen, nutrients, and blood. There's not a single tissue in our body that can survive without those components.
What do you tell patients that this is mostly male patients, I would presume, who say, "Oh, I don't smoke cigarettes, but I do have an occasional cigar," or something like that, or maybe a cigar every other day, or something like that. What does something like that do to the body?
I don't have an answer to that. I mean, any kind of smoke is worse off than no smoke. So then now, and everything is there are things that are okay, and there are things that are straight up bad for you. Cocaine is bad for you. Now, 40, 50 years ago, we used to put, and we still do, you can still find cocaine in the hospital to use it as a vasoconstrictor. So patients that have a very intractable nosebleed will get cotton wad packing with cocaine liquid on it to put up in the nose to vasoconstrict the vasculature and help control the bleeding.
I was surprised to hear that. I just heard that again the other day, that there's actually liquid cocaine that you have in the hospital for those very unique scenarios. My wife told me that, and I thought for sure we had developed some other kind of variant of it, but there's actually liquid cocaine that they have in the hospital. It's kind of like back in the day, they used to actually have alcohol in the hospital to treat those people going through withdrawal. Doctors back then, they used to know where the hospital kept the booze, which was a type of medical treatment for withdrawal. I mean, that's
you could prescribe a beer.
Yeah,
you literally could write a script for a beer.
Come on, you're kidding.
That's serious.
Mm-hmm. I mean, I don't remember how long ago it was it 30 years ago, 40 years ago, that maybe there was this transition away from it, when they developed a better medication. But it was legit treatment for a long period of time.
Well, you just go into the CEO's closet, right?
But to your point, this, inhaling versus exhaling, you're less likely to have the negative sequelae of a cigar than you are a pack of cigarettes. Now, of course, the downside is a lot of people, when they smoke cigars, they might do it in a cigar bar. So now you're sitting in a room surrounded by, you're not inhaling your own cigar smoke, but you're certainly inhaling the secondhand smoke around. So if you're finding yourselves in a cigar bar 3 or 4 days a week, several hours at a time, your risk of having a cigar sequelae of negative outcome problem with the smoking, as opposed to you smoking a cigar once or twice a week on your back deck, is much higher. So we have to be realistic. I mean, we're human beings, especially in today's day and age where nothing's good for you anymore. Having a cigar on your back deck and a sip of brandy, if that's your thing, do it. You know what I mean? Yeah. Having a pack of cigarettes and a 6-pack, maybe not so much.
Yeah. And, Greg, kind of to your point, I mean, it's all relative. That person who is, 100 pounds overweight with terrible bone-on-bone knee pain, they need to be a lot more strict with their diet than the person who is, 10 pounds overweight that's having the knee pain. The same thing, for someone who's smoking a heavy amount, we need to be more aggressive with them. And the person who's otherwise healthy and okay and enjoys the occasional cigar, we're not going to press them as much. We may have other priorities with them. Our health, it's a balance of a lot of different things. And so, everything in moderation.
Yeah. But here's a challenge for us. We talk about health, osteoporosis, sorry, Greg, and preventative medicine early on. I've had conversations with patients that are in needs of, say, joint replacements. There are some very powerful studies out of NYU looking at comorbidities, in particular BMI. So your height to weight ratio. So it's a little bit of an oversimplistic term. Patients that have more lean body mass, more muscle, tend to have a higher BMI, but they're not unhealthy. If I take, for argument's sake, Arnold Schwarzenegger at the peak of his weight training, his BMI height to weight would be through the roof.
Yep.
But then if I take him and underwater weigh him, his BMI would be a quarter of what it shows by height and weight. But the point, that was an exaggeration. I'm just giving an example. But patients with a BMI over 40 have a much, much higher complication with hip and knee arthroplasty. Maybe those patients shouldn't be getting hip and knee arthroplasty. I won't do that. I won't do a hip or knee arthroplasty in a patient with a BMI over 40, because especially if they have comorbidities like diabetes or high blood pressure or so forth. Because now I have a diabetic, hypertensive patient, 2 blood flow problems, that's obese, morbidly obese with a BMI of 40 plus. That's a third complication. When that patient gets an infection or has a wound failure or so forth, that's egg on my face. That's on me. But what do you tell that patient? What do you tell the crippled patient that's bone on bone, like Dr. Joe just said, who needs to work out, needs to exercise, lives in Minnesota, can't jump in a pool or the intercoastal or the ocean very readily, can't do what I tell patients to do all the time, barefoot beach walks, nice low impact, can go knee high in the water, get a little bit of resistance training. What do you tell these patients? It just becomes a never-ending spiral.
Yep, and there's no time machine, because really it's go back 20, 30 years and do things properly. And so, right, there's no time machine. And so unfortunately, it's a lot of hard work. It's taking it really serious. It's going to the primary doctor and it's saying, hey, are my hormones off? Are my labs okay? Is there any medication that I can go on? I hear a lot of patients on Ozempic now that really decreases their need to eat, and they're losing massive amounts of weight. So there's new medications out there that can help people to lose the weight. And if that's not working, I mean, it's something that will really affect your health and your quality of life. So some people need bariatric surgery, and if that's what needs to be done, well, that may be the best thing for you. And so it's really giving that attention and focus, and not just ignoring it. And unfortunately, too many people are just ignoring it.
But
the other problem is, go ahead, Greg.
Yeah, but does that surgery, the bariatric, is that really an end all be all? Because I've heard some people
that can fail too. Yep, that can fail too.
Back to eating.
Yep.
So I did general surgery. I was a general surgeon for 3 years in my residency before I switched to orthopedics, and we had one of the biggest bariatric surgical programs in the country where I did my residency. Of course, everything fails in moderation, and the true proper bariatric patient goes through a workup. They see their medical doctor. They're also supposed to see a psychologist. They see a nutritionist. You don't just go in morbidly obese with a BMI of 50, see a bariatric surgeon, get your stomach stapled or the lat band or whatever the case may be, and then go right back to where you started, because yes, the stomach pouch will re-expand. You can have other negative sequelae, GI leaks, so on and so forth. It has to be you have to buy into a lifestyle adjustment, and the surgery is there to help you, especially help those people that have tried to achieve with traditional means, diet, exercise, weight loss, so on and so forth. And they're just not achieving the goals, not because of them, but because of some other complicated, intrinsic hormonal imbalance or metabolic disharmony in their body. They just need that extra edge to help them to get over the hump. And those patients, they do very well. So is it end all be all? No, but it is of incredible value, because it's helped thousands of people. And of course, there are other failures. You do see the ones that are just as big as they were a year or two later, but they didn't buy into the system. And I mean, and what I was trying to say before, it's a little bit, maybe dicey with this topic that I'm going to bring up, though, but it ties into what we talked about before with the lack of PE in school and the lack of education, the lack of training. We are celebrating almost unhealthiness. I saw an article recently. I have nothing against plus size modeling and various different types of body identification, but there's a reason why we have a scale in our office, and now this idea that you can come into the doctor's office and have a card that says, please don't weigh me because I don't want to know what I weigh. I mean, what? Like, I mean, what is this?
Yeah.
I mean, please, I mean, as a preventative health guy, Dr. Joe, I mean, does that not just infuriate you?
Yep. And, I mean, back to Greg's point here, and what I mean, Greg was saying, is there an end all be all, whether it's weight loss or whether it's pain control, there's not one magic bullet that works. It's not this cortisone shot or this joint replacement or this bariatric surgery. It requires a number of different treatments. It requires a multidisciplinary approach if you want to tackle weight loss, if you want to tackle pain. It's not just come in and get the cortisone shot and I'm out of here and I can keep eating my Big Macs and not walk and not do my physical therapy. You have to buy into everything if you truly want to improve on the pain and have it be successful long term.
Yeah. Yep. Well, how do we find you, doctor? This has been an amazing show. You've hit a lot.
Yeah. All right. Well, you could find Dr. Ed Southard and myself, Dr. Joe Wiersbecki, at Florida Orthopedic Specialists, 335-4770, 335-4770. And we'll be here again next week for Bone Talk.
Sounds good.
All right, guys.
Thank you very much, Dr. Ed.
Have a good one.
Joe. Okay. Have a good week. You've been listening to Bone Talk right here on WPSL, Port St. Lucie. Talk of the Treasure Coast, webcaster to the world on TuneIn.
This is CBS News on the Hour, sponsored by General Steel.
I'm Steve Kathan. Some hopeful signs on the economy. Gas prices at a low not seen since March, and the government says prices at the wholesale level actually dropped from June to July. Mark Hamrick of Bankrate.com.
This is a surprise. Analysts had been looking for an increase of 0.2%. Energy led the way down, and most of the components showed some cooling on the month, with the exception of food.
I'm Jim Crisoul in Oak Ridge, North Carolina. According to AAA, the average price for a gallon of regular gas dipped below the $4 mark this morning for the first time in 5 months.
I saw the gas cheap. $4.
I feel good about it.
It's nice right now. As long as I keep getting it for this price, I can care less how I get it at this price.
The $3.99 a gallon average is 15 cents lower than last week and 68 cents